I'm so glad you're here. Now, I'm not sure what your specialty is, but let's say it's working with trauma. Let's pretend you get contacted by a potential client who has a trauma history, but their chief complaint is anxiety, and they wish to address that first and foremost before delving deeply into their trauma. Chances are you'll feel comfortable working with this client because you have an understanding of anxiety. You likely have a relatively high degree of competence in working with clients who have that kind of anxious presentation, even if it's not your primary area of interest, focus, and learning. If for any reason you chose not to work with this client, you'd probably have an easy time providing referrals. Most of you could easily come up with 2 clinicians who do great work with anxiety, and you could probably come up with more referrals with minimal effort. You will know several modalities that are commonly used to treat anxiety, and you'll know that medication is an option as well. Thus, you might ask if they'd like a referral to a psychiatrist. You will know that anxiety does not need to be treated in an inpatient setting, and since this potential client has not said anything alarming or given you any reason to believe they're at risk of harming themselves, you won't provide any referrals for hospital settings. But now, let's assume this client is struggling with addiction, not anxiety. What's your comfort level in working with them on the addiction issue until they're ready to begin talking about their trauma history? Do you have a broad understanding of addiction and feel competent in working with someone who is in active addiction? If for any reason you chose not to work with this client, how many referral options for outpatient mental health counseling can you provide for someone actively using? Based on what substance or substances they're using, what other referral options could you provide them? If you felt stuck in that scenario, it makes you the rule, not the exception. You're stuck. You might think prevalence, but that's not correct. The numbers between anxiety and substance use disorders are nearly identical. According to the Anxiety and Depression Association of America, the prevalence for anxiety in the U.S. is around 40 million adults. And according to SAMHSA, in 2021, the people who met DSM criteria for a substance use disorder in the United States was around 43 million. Unfortunately, and with dire consequences, mental health and substance use have been historically siloed, leaving people to feel they must choose which issue to address. Clients know that the prevailing views of a substance use disorder are that if you choose to address it, you are choosing abstinence. So if that's not the path they're on, or that's not what they're ready for, then they feel kind of optionless. They feel a little stuck. Further, it's not uncommon for therapists specializing in substance use disorders to work under the condition that the client is no longer using. For me, this has never sat right. Sort of like saying you specialize in anxiety, but require your clients to cease having panic attacks as a condition of working with them. There's also a large population of people using substances who do not need treatment, nor is their substance use even problematic. But again, due to the prevailing culture in our society around drugs, they don't have a safe space to talk openly about their experiences or receive non-biased psychoeducation on safety and reducing harm. Now, without a doubt, drugs can be scary, but especially when we don't fully understand what they are, why people do them, or how to make use safer. And we operate from a space of fear, we diminish our ability to listen and develop connection. It is simply not possible to fully hold space with people when we're overwhelmed by fear or judgment. If a client reveals to me that they're using fentanyl, and I allow myself to operate from that fear space, I'm likely going to begin giving advice or directives. My affect, my body, everything about me will become rigid. And my client will probably experience judgment. It'll feel kind of like a door slam. When we can successfully overcome the fear and judgment, we can attune to our clients. We can listen. We can more effectively meet them where they are. This whole process is about leaving doors open. Even if you don't end up seeing many clients with substance use concerns, chances are your clients will have partners, family members, close friends struggling with addiction. The information and resources we're going to cover can help you in your work with those whose loved ones are struggling with addiction. In this course, we're going to learn life-saving harm reduction interventions, broaden your understanding of drugs, learn about various treatment methods, and when each might be most applicable. And most importantly, we're going to deepen your ability to serve your community. And bonus, we're going to have fun doing it. In 2021, the year that we have the most complete data to date for the U.S., around 43 million people met DSM criteria for a substance use disorder. And 6% received treatment. Now, it's worth noting that around 36.9% of people with anxiety received treatment. And over 106,000 people died from overdose. The devastation from deaths from overdose has swept across all corners of this country and impacted all fields of healthcare. Gone are the days where we can pretend that these issues are relegated to the few. On the chart, you can see the trend of overdose deaths increasing over the years. As helping professionals, we can't assume that handling substance use disorders falls solely to those who have actively sought out to support that population. Because in fact, most people who struggle with substance use disorders don't receive treatment of any kind. Now is the time for all of us in the helping professions to learn to support and connect with people with substance use disorders and their loved ones. As grim as these numbers may be, the situation is by no means hopeless. In fact, there is so much we can do.